for talk about GI and pediatric lab. Oh, change? Sorry, didn't know. So you will do. Okay, so
okay, so I chose this spleen because I think it is it's a common problem that we have a challenge when we do see incidental splenic lesions, and usually I feel sometimes that I didn't know what to do with it, so I decided to investigate it, and that's where the talk came from. When we see the spleen, we have really a grocery list of splenic lesions and differential diagnosis, and the question is, as a radiologist, is how to diagnose the right diagnosis, and is it necessary? So if you look at this, clearly I'm not going to be able to go over this crazy list over here because it's too much for 20 minutes. But from this list, most of the lesions are benign. And some of them are not treatable or don't need any necessary treatment. But some of them, the ones that are highlighted in red over here, are malignant lesions, and therefore we should be diagnosing them. Some of them are infectious, and then some other diseases that are mentioned over here, like sarcoidosis or myeloidosis, that might have some treatment, and therefore the doctor that reports those incidental lesions should find a way to narrow down the differential diagnosis, and this is the role of the radiologist, to suggest if and what further imaging is indicated. We would like to decide when and how to follow up those lesions, and to suggest when to perform a biopsy. So I'm going to do it as a case presentation. That's the way I was asked to do that, and this is the first case. And the first case is hypoechoic or anechoic marked lesion with marked acoustic enhancement. There is a delicate wall, no vascularity in color Doppler, and it's supposed to be like a case study, so anybody wants to say what it is? Not everybody together. So this is likely a splenic cyst, and the question is, should we do any further imaging, or should we follow up, should we do a biopsy? And the answer is, of course, we shouldn't. When it's a simple cyst, it's quite clear that it's just a cyst. But we should know that bruised cysts are quite rare, they're congenital or epidermoid. And when we do refer to cysts, we actually mean false cysts. And these are pseudocysts that are more common and are post-traumatic or post-infection or infarction. And they're clearly evident also in CT scan. We know that they are without enhancement, those hypoattenuating lesions. And over here we have an example of a splenic cyst in an MRI. On the left bottom side you can see the T2, and the T1 with the multi-phased enhancement of the gadolinium shows that the lesion that does not show any enhancement post-Gordon-Swan's administration. Second case, a small echogenic lesion, round, well demarcated, homogeneous, with posterior enhancement. Again, any ideas of what could it be? Well, most of you would say this is an hemangioma. The question is it an hemangioma? So, we have a differential diagnosis also for echogenic lesions. You can see over here there's hemangioma and hematoma, hamartoma, calcified granuloma, in a rare case of littoral cell angioma. All of them could present as echogenic lesions, and even metastasis can present as an echogenic round lesion, and it's a single one even, so it's not so clearly sure that we are encountering with the hemangioma. Over here you can see the lesions that I presented to you, and over here there's another lesions from a different entity that I'm going to reveal a little bit later. So, is it an hemangioma? It is most likely a hemangioma because this is the most common benign lesion that we see in the spleen. So therefore it would be rather safe to say that this is likely to be hemangioma, but is it enough? My answer is no. We should actually do a little bit more investigation. So we should learn a little bit about more about hemangiomas. There are two types of hemangiomas that are known. There are the cavernous and the capillary. The capillary is the one that presents like the hemangioma that is very solid and echogenic and round, and it's very sometimes clear to call it a hemangioma. But the cavernous one is sometimes has a cystic or solid component, and therefore its appearance would not be very classic, the one that we've seen usually at the liver. So, how would this hemangiomas would look like? The capillary hemangioma is going to, as I said, will be in the ultrasound will be hyperechoic with well-defined margins, while the cavernous will be mixed echogenic and hypoechoic, depends on the content, and which sometimes show even partial calcification, cystic structure on sonography. CT scan again, the capillary hemangioma would appear as a hypoattenuating or hypoattenuating well-marginated mass. that will enhance in a certain way. And the cavernous hemangioma will have a combination of the solid and cystic component with enhancement only of the solid part. And also we can have calcification, as I mentioned, it could be curvilinear, could be mottled, central, and sometimes even coarse. The MRI would also be very helpful. We know that in the hemangiomas that would actually appear without contrast, similar to those that's seen in other organs. The MRI most would be hyper-intense on the T1 and hyper-intense on T2. But again, if this is a cavernous hemangioma and it does have solid and cystic component, it would be more heterogeneous. And the enhancement pattern, which is also it's the same for CT and MRI, would be either immediate homogeneous enhancement, it could be early peripheral enhancement with uniform delay enhancement, and it could be the classical one that we know, peripheral enhancement with centripetal progression with persistent enhancement. So, when we do see a lesion that is showing enhancement, that is centripetal and stays later on the later phases, I think that this, when you call it clearly an hemangioma, and most likely this is going to be a capillary hemangioma. And then we can do the definitive diagnosis. But otherwise, not always. And over here you can see how it would look like on an MRI. This is the same patient that I showed you the cyst earlier. If you look clearly now, a little bit, I changed a little bit the image, it's a little bit an image below, you can see that there's a lesion over here that it's not as bright in the T2 as the cyst is, and after giving contrast in the T2 arterial phase, venous phase, and late phase, we can see clearly that this is a continuous centripetal enhancement, showing that this is clearly an hemangioma. And in this patient, he has more than one cyst and more than one hemangioma in his spleen. So you can see again, this is the lesion that I showed you earlier is likely in hemangioma and wasn't hemangioma. But you can see that the lesion that I showed you as a differential diagnosis was found to be a melanoma metastasis, not classical appearance, but still, this is a melanoma, and somebody could mistake and call it a hemangioma. Therefore, I suggest that we always do some contrast enhancement to try to appreciate it. And also you can see that splenic hemangioma could present, as I mentioned earlier, when they are cavernous in a completely different way. They are not echogenic necessarily, and they can have cystic or solid component, and sometimes those mottled calcifications that are within. Case number 3, you can see over here a CT scan on the left image with the peripheral calcification, quite thick calcification. On the left upper quadrant, the same patient with the left upper quadrant definitive calcified lesions. So any ideas of what this could be? Well, I'm hoping that people will be shouting that this is a chenococcal cyst or hydatid cyst, but it also has a differential diagnosis. You can see over here that false cysts, as I mentioned, cysts earlier are usually false. False cyst, this is a picture of a false cyst on an ultrasound. You can see the echogenic rim, which is calcification of the cyst around it. And it could present exactly as a chenococcal cyst. It can present as an hemangioma. We mentioned earlier that they could be calcified in the walls. And it can, even the lymphangioma can present also with wall calcification of a cystic lesion. So what should we do next? Look at this case, for example. This is the earlier case that I showed on the left image. And look at the false cyst. They really do look the same. So calling it a chenococcal cyst would not be necessarily right. We should give a differential diagnosis, and I suggest we perform an MRI and suggest serology for a chenococcal cyst because it is, at least in Israel, it's quite prevalent. So we should do some serological study that sometimes would be the right thing to do and might be positive. And we should look for involvement in other organs because a chenococcal disease would sometimes appear in more than one body organ. Usually when they come only in the spleen, they would present also in the liver. So they usually don't come as a single lesion in the spleen, but they could. And when we do the axial images, sometimes, this is actually not an MRI, this is clearly a CT scan, that shows we can sometimes appreciate the daughter cyst within an hydatid cyst with the peripheral calcification. And in this case, I think this is an meaning we don't really have a differential diagnosis. In this case, we can mention that this splenic lesion is likely or definitely an hydatid cyst. And the MRI clearly has better contrast resolution. Therefore, in MRI, sometimes we can appreciate those cysts much better than we can appreciate them in a CAT scan or a CT scan, sorry, or in an ultrasound. And you can see over here the daughter cyst will be definitely bright because of the content in the T2 weighted images. And on the T1 weighted images, we can see how they would look in the dark. And this is, of course, not a splenic lesion, this is a liver lesion because I couldn't find an MRI that presented with those beautiful daughter cysts. And as I said earlier, we should look for other body organs that might have those cysts, because hydatid cysts usually will involve the spleen and liver together, and this is an example of a lesion in the spleen in a patient that has the definitive daughter cysts in the liver. So the case was the hydatid cyst in this case. The next case, number 4, is a lesion in the spleen. We can see that there's again a cystic lesion, but the walls of it are not as clear as we've seen in the cyst. They are quite thickened. So this is a cystic lesion with irregular thick walls. And any ideas of what the diagnosis might be? Well, again, we cannot really differentiate in those lesions that are with the wall thickening, because the differential diagnosis is not as big as the list that I showed you earlier, but it is a differential. And this could be a pyogenic abscess, infarction, hematoma, hemangioma, metastasis, and a rare case of scoliosis can also present this way. So, the one thing that we should look, for example, of those images, you can see how an infarct looks like exactly like a hematoma, and like ovarian metastasis. They are all present with cystic lesions with some wall thickening that are irregular. So the differential diagnosis, just based on the way it looks on the ultrasound and sometimes on the CT scan, could not be done. But in our case, I will give you something else that you didn't ask me for. The patient is presenting with left upper quadrant pain, tenderness, fever, and leukocytosis. So what would you say? No. So this is likely to suspect to be an abscess. So remember, we do see incidental gliomas, but there's always a patient behind, there's always a history, and it's really important to get this history, because if you do get the history, we might get the right diagnosis. Still, it could be still a lesion that could be from a different entity, so we can do some other images. In this case, we could clearly call it splenic abscess. Why? Because we see the air bubble within it. In ultrasound, we could sometimes see the air bubbles as a dirty cogenicity with a dirty shadowing. And I think that when we do see air within a lesion with a wall thickening, and it is a hypoechoic and there is some content within it, then we can clearly call it an abscess. Otherwise, we should do something else. And what is the something else? When we do an ultrasound, we should appreciate very well the content to see if there are air bubbles within it, if this is just in the, if there's like content within it that is moving sometimes, and if it's a big abscess, and it could be helpful. We can do the CT to assess the enhancement of the pattern of the cyst, because there's not going to be any enhancement in hematoma. The hemangioma, we mentioned that the solid lesions could enhance, and sometimes would enhance and would stay enhanced in the later phases. And an abscess would definitely enhance also the walls of it, and we can perform the MRI for those patients that could not get iodine because of allergy, or when it's young patient. And eventually we should suggest, when we do think that it's an abscess, and sometimes metastasis, and we need to appreciate if it is a metastasis indeed or not, we should do an image-guided intervention to help the clinician. The next case, over here we can see a CT scan with multiple lesions within the spleen, and I'm not going to ask you what it is, because, again, as I mentioned with the thickened wall cyst, with multiple lesions in the cyst, in the spleen, we cannot really differentiate just by the look of it of what exactly it is, because the differential diagnosis is quite vast. It could be abscesses, it could be both bacterial or fungal. Sometimes it is helpful if they are very, very small, if we do know the patient's history. Granulomatous disease, sarcoidosis, lymphoma can definitely appear like that, leukemia, metastasis, and other diseases that are quite rare, littoral cell angioma, lymphangioma, and scoliosis can all present this way. And over here you can see an example for that. You can see the GI metastasis on the left upper image that looks very similar to the one that has the fungal abscess on the left side. The patient with sarcoidosis and the patient with lymphoma. It's even more complicated, because patients that have lymphoma, for example, could have also fungal abscesses because they are immunocompromised. And sometimes it's very hard to differentiate between both. So what could we do? So as I mentioned, imaging could not differentiate between different etiologies. So we have to look for other clues. We have to look for other organs. We have to look for primitive tumor if we know. We have to look for the patient history. And we have to sometimes suggest PET-CT scan for solid lesions to consider and consider a biopsy. And I'm going to go over that a little bit later. So I'm going to a different case now. This is case number 6. Over here we have a lesion. This is also a cystic lesion, but we can clearly see there is multiple septation within this lesion. And I'm going to mention something else. This patient with multilocular cystic lesion is 9 years old, and this is a huge clue for the diagnosis. Any ideas? I'll give you another clue. The differential diagnosis for multilocular cystic lesion is a echinococcal cyst, and it could be lymphangioma, and false cyst or hematoma. They can also appear as multiple cystic lesion. You look at the echinococcal cyst and the lesion that I presented to you, they're very similar. But one thing that could be very helpful for us when we put it on the Doppler, when we put Doppler on a multiple cystic lesions and we do clearly see vasculature in the lesion wall, and I mentioned earlier that the patient is 9 years old, we can think that this might be a lymphangioma. Because the lymphangioma do present with, in the Doppler, with the flow within the septation and within the wall. So lymphangioma is a well-defined hypoechoic mass with occasional internal septation and interlocular echogenous debris. They can be tiny echogenic, there can be some tiny echogenic calcification, sometimes peripheral calcification that can be very helpful on the CT scan. The color Doppler sonography can demonstrate the vasculature of the mass, including the intrasplenic arteries and veins, and that could be very, very characteristic for this lesion. So what should we do with multilocular cystic lesion? We should suggest serology. I mentioned the echinococcal cyst. We should consider lymphangioma when we are speaking about a child and look if he's got lymphangiomatosis. We should complete the imaging with a CT scan or an MRI. We should look for the curvilinear calcification that could be very helpful because they are very classic for lymphangioma. And we should consider that as being a hematoma or a false cyst if the patient has the right history. The patient should have a trauma or an infarct or anything that would suggest this lesion. And this is the way it would present in a CT scan. The lymphangioma, you can see that there's multiple thin-walled, again, attenuation. Typically, it's capsular. We do not see the conference enhancement as we see the Doppler in the ultrasound. And the presence of curvilinear calcification, as I mentioned earlier, could help very much with the diagnosis. MRI, because there is some content within it, the signal intensity of the T1 could be high. There might be bleeding in it, and in the T2 we will see it as a multiloculated, hyperintense areas, and those intervening septa would appear as hypointense event. And unfortunately, I don't have an image for that, and the neurocalcification clearly are not going to be seen on an MRI. So, what is the role of PET-CT? There is an article that was actually coming out from this hospital from combined effort of the radiological and nuclear imaging departments, and they stated that PET-CT can reliably discriminate between benign and malignant solid splenic masses in patients with known FDG-avid malignancy. It also appears to have a high negative predictive value in patients with solid splenic masses without known malignancy. So when we do see an FDG-avid lesion in the spleen, after we decided to do the PET-CT, this is suggesting that it might be a malignancy. And FDG splenic masses in patients without malignancy should also be further evaluated because 80% of them are malignant. So the thing is that if we have, and Dr. Metzer suggested the chart that I found very helpful in practice. When we have a splenic mass on imaging, and we do have a known malignant disease, we should do a PET-CT scan. If the lesion is avid, it's clearly likely to be a metastasis. And if it's not avid, it's most likely, this is what we've showed, the article showed, that it's likely benign, and therefore we can follow up. Now, if we don't have any malignant disease, we could just follow up, or we could suggest to do a PET-CT. And if the lesion is avid, we should look for other malignancy. Even if we don't know if we have a malignancy, 80% of them, as I mentioned, would have a malignancy. And if we just follow them up and they're not avid, we can still, just follow up and see if they're stable in size. And the one thing that I want to show, the last case that I want to show you is a case from our department, not quite a recent one. So this is over here a hypoechoic lesion in the spleen. It's not really anechoic. It appears to be a little bit of solid lesion. And on the CT scan, we can see that the lesion is not enhancing as the rest of the spleen. It's quite well seen on the enhanced images. So the decision was to go to a PET CT scan, and on the PET CT, we can see that the lesion is clearly avid, and therefore suggested for malignancy. And more than that, when we did the PET CT, we also saw that the patient has wall thickening of the left colon that was also avid. So the likely diagnosis was that the patient had malignancy of the colon with a metastasis to the spleen, right? Now, should we do a biopsy? The thing is that you know that with colon, if we have a single metastasis, sometimes we can do a splenectomy, or sometimes in the liver we can do some resection, and that could be the treatment. So the decision was to do a biopsy for the spleen, and this biopsy was performed. You can see the needle over here, and it was found to be splenic lymphoma. The lesion, however, in the colon was only inflammatory. So therefore, it is important to go to perform the biopsy. And just regarding splenic biopsy, because I do know that some people are feeling reluctant to do that because of the fear of bleeding, this is a meta-analysis of 311, not patients, but articles. And there are thousands of patients over here, and they concluded that the image-guided percutaneous biopsy of the spleen demonstrate high diagnostic accuracy, and the major complication rate for needles 18 gauge or smaller that is similar to that reported for the liver and kidney. And the technique should be considered as a favorable alternative to splenectomy. So you have a question and you need to know whether to do a splenectomy. You can always suggest to try something, to try a biopsy first with a small needle. And the needles that we suggest are 18 and smaller. The literature, when I was scanning the literature, I found that the only complication that was mentioned in the literature is when people were using 14 gauge needles. And 18 gauge needles, there were very, very few complications, if at all. Another article also suggests that this was done in children, that the ultrasound-guided FNA and B of the spleen is effective, it's safe, it's a cheap technique, and it's helpful to get a differential diagnosis. And the last article that I wanted to bring is the one that came from Hadassah Medical Center in Israel, and they demonstrated that imaging-guided small bore cutting-edge needle could be diagnostic in lymphoma, not only diagnostic, but it can also was enough to get to the subtype instead of doing a full splenectomy. So, in order to conclude, I would say that when we do have an incidental splenic lesion, we should be familiar with the antecedents. I mean, sometimes we can clearly call what the lesion is. If it's a hemangioma and it's capillary, you can definitely call it. If you do see the Dover cyst, you can call it as a hydatid cyst. And if you do see air and the clinic appears to be consistent with abscess, you could call it an abscess. So the patient history is very important. We should look for other findings in those scans that we're doing, to look for other lesions, to look for a primary lesion if there is a question of malignancy. When we have those solid lesions, those solid appearing lesions, PET CT would be a great idea, because if it's going to be avid, it would suggest malignancy, and not be afraid to do FNA or FNB. Thank you.